I'm a pulmonary critical care fellow from Mayo Clinic, Arizona, and I appreciate this opportunity allow me to share our study findings. This is about comparing diagnostic value of the fungal flip-flop sign versus serology alone in FDG Avid Pulmonary Nodules, especially in Coccidioides-Endemic area. So, just give us some clinical background. We are here, I'm sorry, go back. This is a map. Probably everybody can identify. This is the map of the Cocci distribution. And we're just right here living in the hottest area, kingdom of the valley fever. So we have a lot of patients coming here for the pulmonary nodule. Everybody's nervous about, am I going to get cancer? What am I going to do? Am I going to get this biopsy, right? But after a lot of these investigation, clinical history taking, and this serology and the imaging, we found out, oh, there's some nodules may not be the cancer. For example, pulmonary granulomatous disease can mimic the cancer. It could be the pseudotumor, and even on the PET-CT, it could be FDG uptake avidity. So that leads to a lot of unnecessary biopsies, especially in here, fungal endemic areas. So here, let me share a current workup algorithm in our Mayo Clinic, Arizona. So if we have a patient coming for the pulmonary nodule, right? Then we obtain a clinical history and we do the serology. We got the CT scans and we may ended up getting this PET-CT. Boom, we have this very hot nodule in the right lung. And correspondingly, we have an even hotter nodule, lymph node, in this mediastinum. Or like case 2, we have a nodule here. I'm sorry, it is pretty small, but the lymph node is even hotter. What can we do, right? Are we going to do the biopsy? We're going to get the answer? Well, before we talk to the patient, we need to know what will be the risk coming from this diagnostic procedure, right? These previously, we do a lot of CT guided biopsy, and the diagnostic yield, meaning that it's successful, right? Get the right answer, is about 6 to 90%. And the complication rate, meaning pneumothorax, which is the most common complication from this biopsy, that is 16 to 45%. In the recent decade, we have a more advanced technique, that is robotic assisted bronchoscopy biopsy. The diagnostic yield is better and stable around 80 to 90%. And the complication rate is a lot lower, about 1.5 to 4 patients in about 100 patients. But it's still not benign, right? You still do not want to put the patient on an unnecessary risk. So what can we do for those FDG Avid pulmonary nodules along with the lymph node, right? So we would like to introduce this concept of flip-flop sign. It means inverse relationship in the uptake patterns of 2 different radio tracers. For example, as recall in the case 2, we have the nodule in the lung, which is FDG Avid, but it's relatively mild, but the lymph node is hotter. So the mechanism is the granulomatous lung nodules decrease in activity more rapidly than the draining lymph node. And the Mayo Rochester, they had a study on histoplasmosis. They showed there's a fungal flip-flop sign has a sensitivity about 60% and the specificity about 85%. So hooray, we probably have a solution here. So our goal is to compare the diagnostic value of a flip-flop sign and serology in these FDG Avid pulmonary nodules, especially in here, Coccidioides-Endemic area. And our hypothesis is that the predictive diagnostic value of this combination is better than the serology alone. So we come up with this study. We screened the PET-CT a lot during 2016 to 2021 for all the PET indication of the pulmonary nodules. And we reviewed the EMR, we manually extracted the data, and we included all the patients who had at least one mediastinal or hilar lymph node with the FDG Avid. And we do not want the patients who has known cancer or lack of the pathology confirmation or the follow-ups, and we don't want the nodule growing. So the concept is, if we know what the nodule is, there's no point like we investigate that anymore, right? If the patient has a known history of cancer, we send for biopsy, no doubt. Only for these ambiguous cases, we are not sure, should we do the further investigation to risk stratify that? This is how we define the flip-flop sign. So it includes at least one FDG Avid solid or partial solid pulmonary nodule in the absence of a necrosis, invasion, or calcification. So those are the signs either of a malignancy or this benignity. And we need to have at least one draining lymph node with SUV max level. It is equal or larger than this nodule. And there is no extrathoracic malignancy. And we divide the patients into two groups. One is Cocci serology positive alone. The other one is serology and a flip-flop sign positive. And how we define the benignity. Either we have pathology confirmed that is specific benign, including we found the Cocci, or we found that there is a granuloma, or we do not have biopsy, or the biopsy is non-diagnostic. We are able to follow up the patient for 2 years, and we don't have evidence of malignancy. So our primary outcome is to compare the sensitivity, specificity, and positive predictive value of these two arms, and in diagnosing these nodules, hot nodules. And our findings, we are manually extracting the data, so it is pretty slow. We so far reviewed 76 patients with the complete data, and only 30 met the inclusion criteria. Among those, 6 of them with a positive flip-flop sign, and everybody in these 6 have the positive Cocci serology. We have 22 patients confirmed to be benign, and 15 of them is pathology confirmed, either found the Cocci or granuloma. And we have 7 patients we do not have these biopsy or just non-diagnostic. So we follow up for 2 years and there is no evidence of malignancy. And among these 7, we have 1 positive flip-flop sign. And this is a table. We are looking at this demographic information. Basically, you can tell the age is around 70-year-old, and there's no significant difference between the serology group and the flip-flop group. The gender is evenly distributed. Serology result, they're all 100%. Honestly, I have no explanation why this p-value is lower than 0.001. They're all 100%. But the location is evenly distributed. There is no significant difference. And benignity is similar. If we are looking at the pulmonary nodules alone, so we can tell the maximum size of the nodules in the serology group is larger, right? They're 25 on average, medium. And in the flip-flop group, that is a little bit smaller. In terms of the SUV levels, there's no significant difference, but we can tell this serology group is a little bit higher, and the flip-flop group is a little bit lower, even though the significance is borderline. In terms of draining lymph node, of the size, there's no big difference. I apologize for this 0.011 of the p-value. Apparently that is not accurate given this serology group, the confidence interval, it is within the serology group. So I do not think that is a significant difference. In terms of SUV level of the lymph node, serology group is higher, is lower, and the flip-flop group is higher, as expected. This is how we define the flip-flop sign, right? The lymph node should be higher. In terms of the difference between this lymph node and the nodule, that is similar among these two groups. The next is the most important thing. We are evaluating the sensitivity. The sensitivity is higher in the serology alone group, it's about 70%. And the flip-flop group is only 1 out of 5 is positive. In terms of specificity, flip-flop group is a lot higher, 87%, very impressive. But the positive predictive value, the flip-flop sign is also performs very well, acceptable 83%. I like it. Now we're looking at the odds ratio, unfortunately. None of the odds ratio is significant, no matter the univariate or multivariate regression analysis, because our confidence interval ranges from 0.1 to hundreds. Well, we only have 6 patients. So we have some prior studies. So like the Coccidioides-Pulmonary nodules, they take up FDG less than the malignancies, but there is a significant overlaps. And there are some studies showing that, oh, maybe dual time PET-CT, meaning that we do a PET-CT now and repeat another one later. And this fungal infection, the benign inflammation, they were getting lower FDG uptake, but the malignancy were higher. But this is not that practical in clinical settings. We always have a long line waiting for the PET-CT. In terms of Mayo Rochester data, they have a sensitivity is pretty high, and specificity is not as good as ours. But the sensitivity, why theirs is higher? They're studying histoplasmosis, right? They have a higher and more robust inflammatory response compared to Cocci. So that probably why. So we conclude that the combination of the serology and these flip-flop sign can help us on decision making, maybe. And serology has a higher sensitivity, and the flip-flop sign has a higher specificity. I mean, the combination. And the positive predictive value of this combination is pretty good and may help us in the shared decision making when we see in the patients. But we definitely need a larger study to help us for further investigation. Thank you.
We have time for questions. Well, we do have one from the chat group here. Have you or anyone seen this paradoxical reaction in coccidioides infections treated with standard therapy like fluconazole? I have a patient who improved initially on fluconazole for pulmonary cocci, who a month later developed scrofula. Oh, this was probably for George's question. So, sorry, we'll have to get you to George later, Dan. Any questions for this presentation? Yes.
Just wanted to make sure that you be aware there could be a cancer and cocci together.
In the context of?
It could be, well, there are patients that have the risk factors, they get cocci on top of cancer.
Oh, yes,
or the cancer
right.
comes back after the cocci.
Right,
So
exactly.
those are the confusion parts.
Exactly. So when the patient has the cancer, we know the patient had a history of cancer, no doubt we send for biopsy. So only for those patients, we do not have the history and we're not sure what to do next. We're hoping to have a way to help us to like risk stratify. If we are comfortably just following the patients over time, well, we just send for the biopsy. Yes, I know. Yes, Cocci does not protect the patient from cancer. Yes, you're right.
Thank you.
Thank you.
Our next presenter is Nalini Kala, developing a flow cytometry-based assay to diagnose and monitor valley fever cellular responses.